We now are going to hear from two expert speakers on treatment, particularly focused on methamphetamine treatment. At first, can I please welcome Professor Nicole Lee? You met Nicole yesterday afternoon. She is Adjunct Professor at the National Drug Research Institute at Curtin University and Director of 360 Edge. And the respondent will be Dr. Vanessa Caldwell, National Manager at Matuaraki. And Vanessa leads the methamphetamine initiatives for Matuaraki. Hi, Nicole.
Okay, wow, what an amazing 2 days it's been. Thanks so much to Ross and to the NZ Drug Foundation for inviting me. I feel so privileged to be invited to talk amongst especially this enormous lineup of powerful women in drug policy. I am going to do something a little bit different. I think talk a lot more about treatment and about how, I'll touch a little bit on how our drug laws might affect how we provide treatment and some of the lessons that I think we should learn from the meth issues that we've had in Australia, and I believe you've had here as well. So, as Monty Python said, it's not a good photo, is it? Now for something completely different. Here we go, let me see. All right.
Tearing apart the fabric of community. It's not just the victim that's the victim. It's the friends, it's the loved ones, it's the mother, the father, the sister, the children. They're the victims.
Australia is under siege.
I want my police station to be full of criminals.
You lose your soul, you lose everything.
Worse than heroin, worse than coke, worse than pot.
We are the world's second highest users of crystal methamphetamine. Street name, Ice.
1.3 million people in Australia have tried ice. Some of your friends and members of your family would have to have tried ice.
So that was the first 40 seconds of a documentary that aired earlier this year, as you can see, February 7, 4-part documentary on methamphetamine in Australia. Most of that 40 seconds was rubbish, and I'll show you why in a minute. But it's pretty typical of the extreme hype and the war on drugs messages that we've been getting in Australia, particularly through the media, that has filtered through to public debate and political debate as well. And as you can see, it's absolutely frightening. It's been pretty effective in influencing public opinion too. In a survey of the general public in 2015, about 90% of people who were surveyed overestimated the number of people who use meth in Australia, and almost half of them thought that between 30 and 100% of the population had tried ice. The true figure is closer to about 5%. And for the first time in our 3-yearly National Drug Strategy Household Survey, meth is now the drug of most concern to the general community. It was 16% of people in 2013 said it was of most concern, and 40% in 2016, so that's increased significantly. And clearly the media play an important role in driving the public agenda, and particularly public opinion, and I think it's probably more so for alcohol and drug issues. Because when you think about it, where do people get their information about alcohol and drugs? There's not that many places where the general public can get information about alcohol and drugs except through the media, and then bombarded every day with drug messages, war on drug messages through the media. The average person, all of us in this room, are in contact with people who use drugs or drugs themselves, but the average person probably wouldn't ever come across someone who used drugs, and if they did, they probably wouldn't even know that they had used drugs. So most of what they learn about it is through the media. And we know that media and public opinion can be important influences in drug policy, and in Australia, this little gem from the Abbott government, the previous Abbott government, reflects that significant influence. So this was an ad, a series of ads that were displayed in Australia over a period of time, about 8 weeks. So currently, Australia is on absolute high alert when it comes to methamphetamine. And all of this media reporting, these ads really have only served to stigmatise people who use methamphetamine and other drugs as well. And what we know is that when people feel stigmatised, they don't seek help, and that's the opposite of what we want to see happen. Now, all of this has occurred at a time, just look at that dark blue line, don't worry about the rest of it. All of this has occurred at a time when the reported use of methamphetamine itself continues the downward trend that we've seen over the last 20 years. So it's not even just a recent downward trend, it's been happening since 1998. There is a problem, though, in terms of methamphetamine. It's just not the problem that the media have led us to believe. The problem with not understanding what the actual problem is that we're currently misdirecting our attention and misdirecting our funding to the wrong place, and we're never going to be able to solve the problem to do with meth. So there's not been any evidence of an increase in the prevalence of methamphetamine, but what we have seen in Australia is a change in the way people use it. So firstly, there's been a decrease among current users in their reported prevalence of the powdered form, which in Australia we call speed, and an increase in the preference for the crystal form, which in Australia we call ice. Now, these are the same drug. If you use enough speed, you'll get the same effects as ice. They're made differently, and they appear different, but it's kind of like, I think of it kind of like if you think of an alcohol analogy, speed is like light beer and ice is like vodka. If you drink a can of light beer, you'd probably maybe feel the effects, but you wouldn't feel too drunk. But if you drank 285 mils of vodka, some of us would maybe not feel would be fine, but most of us would probably be under the table. So it's that kind of difference, but they're all alcohol, they look different, taste different, made differently, but they have the same effect, and that's the same with methamphetamine. So when we talk about ice, we're really just talking about a stronger form of the drug. As well as a change in the preference for the stronger form, we've also seen an increase in purity and a decrease in price. And that's kind of created this perfect storm for problems. So while we haven't seen an increase in the use of meth, we've seen a decrease in the use of meth, but we've continued to see an increase in the harms because of the way it's used. And this is directly reflected in a whole range of other data sets. So we've seen treatment presentations nearly double. Hospital separations have increased, particularly mental health hospital separations. Ambulance call-outs have gone up about 25%. Emergency department presentations and drug-induced deaths have all increased as well. But what it demonstrates is that a focus on use of a drug and how many people use the drug is not necessarily that helpful in responding to problems associated with drug use. We can see here that drug use has gone down, but harms continue to increase. And we need to switch our policy focus from use to harms if we're going to respond more effectively across the board. If we just focus on the number of people using, our attention is necessarily drawn towards law enforcement. We're trying to reduce the number of people using by reducing the amount of drugs in the system. And we're trying to eliminate use. And therefore, we end up with the war on drugs. But the drug's not really the problem itself. This is a Benzedrine inhaler. Excuse me. It's a form of amphetamine that was around in the 1940s and 50s. It has a piece of paper inside that's laced with amphetamine, and it was sold everywhere. You could get it anywhere, over the counter at the pharmacy, even, I'll show you another. So this is a Pan Am service menu. You can see here that there's Benzedrine inhalers on the service trolley. So it was marketed as a pick-me-up on a long flight, jet lag, motion sickness, but also for depression, tiredness, overweight and obesity. I like this, that the alcohol and cigarettes you had to pay for, but the amphetamine was free. So this was in 1948. In the 1940s, about 10 million of these were sold or dispensed at a time in the US, at a time when the population of the US was only 90 million. So it's a lot of people using, and there wasn't really that many problems. So it just, I guess the point is that it's not really about the drug itself, it's about who's using and the way they're using and what they're using. So just to emphasise all of this a bit further, this is a breakdown of the National Drug Household Strategy survey from Australia. And you can see that 70% of people who use methamphetamine use less than 12 times a year. And most of those people only use once or twice a year. And we've been talking a lot about harm reduction, and this is why harm reduction is so important. And another 15% are what I would call occasional users, so they use less than 4 times a month. And then another 15% are regular users who use once a week or more. And what we know about meth is that if you're using more than once a week, so 2, 3, 4 times a week, you're highly likely to be dependent. So we've got a dependence rate of about 15% among people who use meth. So 85% of people are not going to come ever anywhere near a treatment service. But they're at risk of significant harms. You can see here, this is the number of people, so the percentage of people who use methamphetamine who use other drugs. Hope that makes sense. The red is the general population. So for example, just on the very left, for cannabis, about 10% of the Australian population have used cannabis in the last 12 months, but about 73% of people who use meth have used cannabis in the last 12 months. So they're very heavy poly-drug users, and we know that every time you add a new drug to your list, you're increasing your risk of harm. So the more drugs are used, the more harm you're likely to experience. So this means for this group of people, harm reduction is absolutely critical because it applies across the board to everybody, but 85% of people are never really ever going to come into contact with health services in order to get any information about reducing use or reducing harms. So it's absolutely critical to reduce the problems associated with methamphetamine. So can you guess which of these numbers is the percentage of drug funding that is directed towards harm reduction? It's not 66%, I can tell you that. So despite the fact that most people who use drugs are at risk of harm but are not at risk of dependence, only 2% of our drug funding goes to harm reduction. And thank you to Alison, this is from her work, Alison Ritter's work at DPMP. And again, only 22% of the drug funding goes to treatment even. Most of it, 2/3 of it, goes to law enforcement. And that's a direct result of our the way we apply our drug policy and our drug laws. So Australia has a drug policy that we call the 3 pillars policy. It's focused explicitly on harm minimisation. The 3 pillars are harm reduction, demand reduction or treatment, and supply reduction or law enforcement. But the application of the policy, as you can see, is heavily influenced by the war on drugs. It's mostly going to law enforcement and the reduction of use, and not into the reduction of harms or treatment. Oh, sorry. So I just want to switch a little bit and I'm a psychologist and I can't stop talking about clinical things. So I just want to switch a little bit and talk about what the meth issue has taught us in Australia and how that impacts on treatment. And from the treatment perspective, you've probably seen pictures like this all over the place, probably not quite like this one, but roughly. But if you've had a look on those websites, on the bottom in the fine print, it often says things like, changes may not be due to meth, because it's a lot more complicated than just the drug itself, as we've heard over the last 2 days. What it means really, from that previous slide, I guess, that the war on drugs means that our treatment services are chronically underfunded, and I heard that in New Zealand it's not a particularly different story. And often in Australia, when we have cuts to health, alcohol and drugs is the first to receive those cuts. Because we're kind of, I think the undertone is that people who use drugs are unworthy and they're easy targets. So because we have a system that's chronically unfunded as a result of the way that we perceive drug use, we have ended up with a system that is inflexible to changes to drug patterns, and this is what the changes in meth use have taught us. These were very pretty sudden switches in the way that people use drugs, relatively quick changes, and our treatment services weren't equipped at all to deal with them. They're only barely getting by dealing with the traditional drugs that they're used to, alcohol and heroin and cannabis. Alison Ruder mentioned yesterday that our treatment services, not only do they only receive 20% of the drug funding, they're actually funded at only half the level of the need that's out there. And so we're continuing to implicitly punish people who use drugs. So I just want to talk a little bit about what's kind of unique about methamphetamine and why we've had difficulty adjusting our treatment services. The use of meth increases a whole range of things in the brain. It's got a very, very complex action in the brain, and it's so complex. I think this is the reason why we haven't been able to find a pharmacotherapy that would be helpful for replacement. The main increases in neurochemicals in the brain are serotonin, which is the thing that is increased with ecstasy. So if you've seen people who are on ecstasy, you're so beautiful and I love you and everything is so wonderful. That's the serotonin effect, and that has a little effect in meth, but the main effects are in noradrenaline and dopamine, so they're both increased significantly. Noradrenaline is our fight or flight activator. So people who are using meth often have their fight or flight system switched on artificially, and that's why we see an increase in aggression among people who use meth. There's not been any documented direct link between methamphetamine and aggression and violence, but it works by raising threat sensitivity, is what we would call it. But the main, the main increase is in the dopamine system, and that is a system, some of the estimates are that system is increased by about 1,200% on baseline levels. So it's significant increases in the levels of dopamine in the brain. And that's our pleasure and reward system. So anytime we do something nice, get a little burst of dopamine, and it tells our brain to do it again. So it says, oh, that was nice. And it acts as a kind of reward loop. So what happens in the brain normally is that the blue things are dopamine. That's not what they really look like. That's just an image. It do something nice and little bits of dopamine get released, and that passes the message on, and the brain goes, oh, that was lovely. But when we have meth on board, any second now, so most of them kind of get used up or get recycled, but when meth's on board, loads and loads and loads and loads and loads of dopamine gets released, and the meth itself blocks the recycling process. So that keeps a lot of dopamine in the system, but it also means that there's no dopamine to recycle, and eventually your brain runs out of dopamine. It's kind of like you've got this bucket of dopamine, and you empty the whole bucket all at once, and then there's none left. So that's why people who use meth, they might use on a Friday or Saturday night, and Sunday they'll feel like shit, and they'll just want to sleep, and they feel really tired and flat. And Monday they might feel a little bit better, but they'll take the day off work, and Tuesday they're good to go again, right? But if you do that over and over again, so if you're one of those people that uses methamphetamine 2 or 3 times a week, and you're putting yourself at risk of dependence, you never give your brain enough time to recover its dopamine stores. And that means that the dopamine system then decides to shut down. It says, bugger this, I'm out of here, and starts to shut down all those transporters and receptors. And then even when you've got dopamine on board, you don't feel that pleasure anymore. I will explain why this is important in a minute. So this is a brain, as you can see. For those of you who've never seen a brain before, the red bit is the front. And that's around the front of the front part of the brain is called the prefrontal cortex, and that's really important for thinking and planning and decision making. And then inside, if you cut the brain in half, on the inside bit is the limbic system, and that's responsible for emotional and social processing and memory. And this is important because the dopamine pathways run right through both of those systems, and if you have stuffed up your dopamine system, then those systems don't work very well. So not only do you have trouble thinking and planning, and your emotional and social centres aren't working very well, but those two things need to talk to each other all the time so that our emotions stay in check. So for example, if you're walking in a dark alley and something jumps out at you, your limbic system will go, holy cow, and your mine says holy shit, but prefrontal cortex will go, it's okay, just a cat, calm down. And so your brain's kind of got to be doing this all the time. And if you've used meth chronically and you've stuffed up your dopamine system, then you're going to get lots of emotional dysregulation as a result of that, and an inability to remember things, and difficulty with planning, decision making, and a whole range of higher order thinking processes. And neuroscientists have found that those impairments to the dopamine system are larger than cocaine and cannabis, and even larger than Alzheimer's disease. So they're pretty significant changes that happen in people who use methamphetamine chronically. The other thing is that after 6 months of abstinence, the thinking processes are actually worse than when they were currently using. So not only the system's not feeling great, even after you stop using, you're not going to feel okay, even for at least 6 months. And there doesn't seem to be a huge improvement in the first 12 months. So I hope you can start to see how this is going to impact on our treatment services. The other thing that's important is that This is, here, sorry for you on that side. The blue line is acute, kind of the shape of acute heroin and alcohol withdrawal. This isn't data, by the way. I have to say that now because this suddenly appeared in the Prime Minister's ICE Task Force report, labelled as if it was actual proper data. They didn't ask me, obviously, if they could use it. But after you stop using, you get an acute kind of increase in withdrawal symptoms, and then you have this kind of reduction in withdrawal over about 5 days. But for meth, you can see that process is a lot longer. It's actually about twice as long, so it's 10 to 14 days. So what happens is that we put someone into detox, and we either discharge them at the 5 to 7 day point because that's how much we're funded for, and you can see they will be still in withdrawal at that point, or we keep them in there for 10 to 14 days and they use up 2 beds. So the services are in a bit of a dilemma because they're not funded properly in order to respond to this different pattern of withdrawal. And then you can see this cognitive recovery takes 12 to 18 months. This is this is data from a survey that we asked people who are in treatment about their natural history of withdrawal and recovery, and you can see from first use to first regular use is about 2 years, but there's quite a quick, a short period of time between first regular using and first having problems. Only about a year, but you can see here from first regular use to first drug treatment is a really long time. It's like 5, 6, 7 years before someone comes into treatment after they've first realised that they have problems. And as a result of that, when people come into meth treatment, they tend to have quite high social capital. So they still tend to have jobs, they tend to still be engaged with their families, and they have stable accommodation. And there was one study that showed that about 85% of people who use meth in meth treatment have stable accommodation, and more than half of them are still employed. The other thing is that there's a pretty short intervention window for methamphetamine treatment. So people who use meth only stay in treatment on an average for 3 sessions, so you don't have that long to treat them. But when we think of treatment, and when the government thinks of treatment and what they're going to fund, the first thing they think of is residential rehab, 6 to 12 months of intensive work in a residential facility, and that's not necessarily the best thing for someone who's using meth. But we do know all of these things work effectively. But what we need to be able to do is to fund a range of treatment services, not just residential, intensive residential services and counselling. And brief interventions, day rehabilitation and harm reduction are either not funded in Australia or severely underfunded. Meth users actually, there was a study in Australia that showed that they have actually the highest success rate in treatment, which is often surprising to people. But what does happen after treatment is that they relapse at a really high rate. So, let me link that back to all of the brain stuff. That is why, because there's that long cognitive recovery. It's 12 to 18 months of feeling like crap, even after you've got off the drug. So here, this is a study from Rebecca McKeaton, just looking at outcomes from treatment. The red line's the people who went through residential rehab. They're doing pretty well at 3 months, but by 1 year, about nearly 80% of them, 78% of them have relapsed, and by 3 years, 90% of relapse, they look pretty much the same as someone who didn't have treatment at all. And these 2 studies here, this is one, a brief intervention study that I did with Amanda Baker. We measured at 6 months, so you can see it's bang on. And this is the study that showed, the 74% is the study that showed that meth users have the best outcomes in treatment. So that means, to me, that says it's kind of relatively easy to get off meth from any type of treatment, but it's really hard to stay off it, and there's no post-treatment support that is funded in Australia. And so what we do is very reactive. We get people into treatment, we fix them, good on you, off you go, come back and see us once you've relapsed. And that's not going to be the best option for reducing use and helping people. So what is not funded that could be useful in this period is peer support, support groups like Smart Recovery, booster sessions, telephone call every now and then. Clinicians say they just don't have enough time to do all of those things. So this post-treatment period, although it's absolutely critical, is lacking funding because of the way that we fund our treatment services, which gets back to the war on drugs. So I'm just going to finish with a quote, again from Alison Ritter. The kind of treatments we provide influence whether people want treatment, and if we don't provide the right system, we won't have the demand for treatment. And to do that effectively, we need to properly fund the treatment system, a treatment system that's flexible enough to respond quickly to changing patterns in drug-related harms. And to do that, we need to focus on harms rather than use. And to do that, we need to end the war on drugs. Thanks.